Hello, good afternoon. Thank you everybody, and I really want to first thank the SSRC committee for inviting me to talk on this important topic which is near and dear to my heart, which is SLE. And I'll try to do my best to give you a snapshot of what we have accomplished in SLE in the last 1 year. So as you know, SLE affects people, all over the world, and there is a trend that SLE is kind of increasing in Middle East and North Africa, and we see now the overall projection between 2018 to 2028 is roughly about 32%, 1/3 of the total population of lupus, and the Asian population being roughly about 53%, which is projected since around 2018. Keeping in mind that trend, so going back to United States, what is the prevalence of lupus? We know there is roughly about 200,000 lupus population in United States based on the last census data in 2019. But I just want to highlight this important concept that there is about 32 million American population have positive ANA, which accounts for about 13.8%. But of course, all of them don't have lupus. So just for not the established rheumatologists, but maybe for the fellows and the residents, ANA is thus not a lupus test. Pathogenesis of SLE, just to be very brief, it goes into 4 different stages. We start with the genetic and the epigenetic factor that you see at the left lower bottom, and then if there is autoimmunity which is triggering, and that leads to the generation of different oxidative stress and defects in all the cell signaling, leading to overall loss of tolerance. And then you go to the preclinical stage of lupus, which is typified by B-cell lymphocyte stimulator or BLyS, interferon alpha, CXCL10, CCL7, so on and so forth, and finally leads to the overwhelming of the immune system, leading to the full-blown manifestation of lupus, leading to the generation of different autoantibodies, double-stranded DNA, anti-Smith, low complement, so on and so forth. So there is some change in the paradigm. What is the paradigm shift that we are seeing? We are seeing that there is now a lot of thoughts about the microbiome in lupus and something that we call the leakage of the gut bacteria, mostly in relationship to Enterobacter gallinareum, that is supposed to be associated with lupus in mice. And this is a very new concept, and in fact DNA from this Enterobacter gallinareum has been shown to actually found in the liver of the patient of lupus. So this is a new concept about leakage of the gut bacteria, which is also called gut dysbiosis, leading to microbiome alteration in the milieu of our lupus patients. Coming back to the genetic model that we know for quite some time now, that adults with systemic lupus, they exhibit some distinct molecular signature. If you look at the heat map on your right-hand side, there are 7 different clusters, cluster 1 to cluster 7. I like to draw your attention to the yellow cluster, which is in the middle, as you can see. The higher the yellow number is, the more is the upregulation of the gene, clearly showing that there is a different genetic signature based on the heat map. Some are upregulated, some are downregulated in lupus. It is the imbalance between that up and down regulation in lupus which actually leads to the genetic alteration in the lupus pathogenesis, leading to the proliferation of the disease that we see ultimately as clinical lupus. Also, we know very well, not unknown to this astute audience, that there is a new classification criteria for lupus based on the ACR-EULAR Combined Committee in 2019 led by Sindhu Johnson, and it is a point system, as you all know. You have to get 10 points, and that will 10 points or more or give you the diagnosis of lupus. Just to keep you in mind that if you get 6 points, that will be given through presence of small joint involvement, 2 or more tender or swollen joints, and also if you get some other severe organ involvement, that also gives you 6 points. But 6 points is not enough. You also have to get a total of at least 10 points as shown there in different organ system. This is just a snapshot, but the entry criteria that has been changed is you have to have 1 to 80 positive ANA only by indirect immunofluorescence or IIF titer, not by ELISA, not by multiplex technology. So this is the way you have the entry criteria for lupus. Otherwise, the patient is out the door. So keeping in mind the lupus impact on mortality and organ damage, without talking a lot about it, just to give you an idea that roughly if we look at the BILAG score, which is the British Isles Lupus Assessment Group score, if there is a single point increase in the BILAG, that leads to about 8% increase in the risk of organ damage. And that increase in the BILAG score actually is associated with increase in mortality rate. How much? It is about 15%. And if you look at the data in terms of SLEEK SLE damage index, also called SDI, each unit increase in the SDI will culminate into 34% increase in risk of death. So patients thus with SLE compared to the general control population, based on the beautiful paper by Lopez et al. And by Wartel, it's roughly about 2.6% more than the general population. So what we have accomplished in terms of lupus therapeutics in the past decade. A lot to talk about. In the interest of time, I'd like to be as brief and as concise as possible. So this is the potential tailored treatment in different autoimmune disease, published very elegantly in Nature Medicine in 2022. I like to draw your attention to the lupus part. I know I don't have a pointer here, but if you look at exactly in the middle, that's the SLE. And you can see there are 2 important players they are talking about, which is the belimumab and the other is interferon. And if you can think about the overall 2 important genetic contribution, what is HLA-DRB2 and the other is HLA-DRB3, and then the role of interferon and the BLyS were the 2 important genetic and molecular targets for lupus, and there are more to come. So it's not all about rainbows and butterflies. There are a lot of failure in the lupus therapeutics. We have at least 10 clinical trials that has been failed in lupus, and these have been listed here, but without looking at the failure, let's try to look at the glass being half full. Let's try to look at the success, what we have accomplished in lupus. So back roughly in 2011, after about 50 years or so, we have the first biologic that was approved for the treatment of lupus, which is belimumab. And as you know very well, belimumab works by blocking BLyS or BAFF, which is B-cell lymphocyte stimulator or B-cell activating factor. And it does not directly work on the B-cell receptor. It rather blocks the soluble BLyS or BAFF and thereby prevents the association on the B-cell receptor and prevents the development of the autoantibodies. It also causes prevention of the development of the autoreactive B cells and development of the autoantibodies. And of course, these are the clinical trials that you all know very well. One is BLyS 52 and BLyS 76. BLyS 52 has an effect size of about 14%. BLyS 76 has an effect size of about 9%. And in this BLyS clinical trial program, there is also a very clear indication of oral corticosteroid dose reduction, as well as there is a clear indication that in this situation, using belimumab, there is reduction in the annual flare rate. They don't have a very clear-cut achievement of skin response on belimumab from the BLyS trial, but there is some data on the post-hoc analysis. So what's the next molecule is the molecule that will block the type 1 interferon in SLE pathophysiology, as I show in the later in Nature Genetics, the article. So interferon. So interferon was first known to us in 1957 by Lindemann and Isaacs, when they actually showed that when the heat activated the influenza virus and inject in the chick embryos, the chorioallantoic membrane are not actually having any activation of those influenza virus that the heat activated and injected in those chicken embryos. Then they found there should be a factor that is interfering the replication of the influenza virus. So they called it viral interference, and then fast forward in 1979, those viral interference was called viral interferon, which was published first in the New England Journal of Medicine in the same year. Fast forward in actually 1990 and 1991, it was first shown that there is evidence of increased lupus-like syndrome when interferon is used to treat either cancer or hepatitis C. And even fast forward 2003, the interferon gene signature was mapped, and in 2005, it was shown that the high interferon gene signature is associated with lupus activity as well as presence of autoantibodies. So keeping that in mind, what are the other targets of SLE therapies? But before we go into that, the signaling cascade for interferon, as I explained to you before very well, so one of them is really through blood dendritic cell antigen, or BDCA2. So what happened, this blood dendritic cell antigen, it actually is associated with CD32A, also called FC gamma 3A, that actually associates with this BDCA2 to cause actually the signal into the endolysosome, and that works through TLR7 to 9 in association with MyD88, and that leads to the expression of the interferon regulated genes. So if there is a way to block this blood dendritic cell antigen, or BDCA2, it will not be able to associate with the CD32A, and that will not going to lead to further signaling inside the nucleus, where actually the interferon gene is produced by the plasmacytoid dendritic cells. So hence, blocking the BDCA2 makes sense. So hence, there is actually a clinical trial, and as BDCA2 is also now known as litifilimab, and there is paper published in New England Journal of Medicine showing there is positive effect, and the phase 3 trial is enrolling. In terms of the interferon type 1 blockade, as you know, interferon type 1 has 5 different subtypes: alpha, beta, epsilon, kappa, and omega. So anifrolumab is the molecule which is a pan type 1 interferon blockade. It is a monoclonal antibody that blocks all the 5 different subtypes of type 1 interferon. And it does so by blocking one of the receptors called interferon AR1, and by blocking the signaling of the interferon R1, as you see, the blue triangle is really the anifrolumab, and it binds with the interferon AR1, as you see in the cartoon, and that prevents the association of the interferon R1 and interferon R2. Those are the 2 receptors to bind to anifrolumab. So that interrupts with the receptor ligand interaction, and because of the binding of anifrolumab to IFN AR1, it causes internalization of that part of the interferon receptor, and thereby less number of receptors are available for assembly, and hence there is less availability of the signaling through the interferon. Also, because of this blockade, the downstream inflammatory as well as immunological processes are prevented, and also it works also indirectly by preventing the plasma cell differentiation, and also helps to expand the T cell subsets and trying to restore the imbalance in lupus which is inherent. So anifrolumab was evaluated in 3 clinical trials, one phase 2, which is on your left-hand side, which is called the MUSE trial, and 2 phase 3 trial, TULIP-1 and TULIP-2. So in the MUSE trial, the primary endpoint was met, which is SRI-4, as well as sustained reduction in oral corticosteroid use in 24 weeks, and the effect size was roughly about 17%, 34 versus 17%. If you look at the TULIP-1, the primary endpoint, which was SRI-4, was not met because the effect size is only 6%, 48% versus 43%. But in TULIP-2, the primary endpoint was BICLA, which was definitely statistically significant, with the effect size being about 13%, which was statistically significant. So keeping those 3 trials in mind, this is another important thing that came out of the long-term extension of the TULIP program. So TULIP program was for 1 year, but from year 2 to year 4, so another 3 more years, there is a long-term extension of the of this anifrolumab TULIP programs, which is called the long-term extension. And this extension trial, to make the long story short, it clearly said that there is 2 things that was accomplished. Not only this, although the extension trial was primarily a safety trial, but efficacy was shown in this long-term extension for 3 years. The efficacy that was shown is there is not only reduction in the SLEDAI-2K, but also there is definite reduction in the use of steroid. So as you can see, the magenta color is anifrolumab and the gray color is placebo. And if you follow along in terms of the lines, the magenta color is on the bottom and the placebo is at the top. On the left-hand side, if you see the SLEDAI score, on the right-hand side, you see corticosteroid use. The bottom line is that there is less corticosteroid use and better improvement in the SLEDAI score with the anifrolumab compared to the placebo. And remember, placebo is not just placebo. Placebo really is the standard of care, just not the anifrolumab added to it. So this is a very important graph. I am not going to make it more complicated by reading to you each and every part of the histogram, but the bottom line is that in this long-term extension study in the TULIP program, so total you are looking at 3 years of long-term extension after 1 year of the actual trial. There is definitely reduction of the corticosteroid, and the nuts and bolts of this corticosteroid reduction is that overall only 9% of the anifrolumab patient were using steroid greater than 7.5 milligram per day compared to 29% in placebo. And up to 5 milligram, which is 0 to 5 milligram of prednisone, that was used only in 37% in the anifrolumab group compared to 74% in the standard of care in the placebo group. So also if you do stage by stage, at each stage of the game, at year 1 to year 2, 2 to 3, 3 to 4, at each stage there is less use of steroids in the anifrolumab arm in the long-term extension compared to placebo. Also, about 96% of the patients in the anifrolumab arm had no flares at the end of the 4-year period. And this is also very important. So the flares were significantly reduced for those folks who continued anifrolumab over the period of 4 years comparing against the placebo.
1 minute left.
So next we have the other types way to inhibit the type 1 interferon. One is the blood dendritic cell antigen that I already explained to you, and that is called the litifilimab, which is the specific molecule now it is called, which is actually, the data is present in the New England Journal of Medicine in 2022, both in the skin as well as in the joints, 132 patients. There is 16-week data. It shows that there is reduction in the CLASI in the joint. There is also data which shows there is reduction in the joint counts at 24 weeks. There is a molecule called Viela, which is name is complicated, VIB3A737. It's a monoclonal antibody specific for ILT17, which is a surface protein for plasmacytoid dendritic cells. So naturally, if this cell surface protein is not available, there will be not enough plasmacytoid dendritic cells and less interferon. That's the other way also to stop the production of the interferon. Few other molecules. How much time do I have?
We have only less than 30 seconds left.
Okay. Just 36 seconds?
Yes, according to the timing.
Okay. All right, I'll finish up very quickly, but these are just a few kind of food for the thought. So there is a cereblon inhibitor, which is also called CCT20. There are two molecules. One is called iolose and the other is called icarose. These are the two regulators of lymphocyte development, homeostasis, and lymphoproliferation. If you look at the right-hand side, when the lymphocyte development is deranged or there is dysregulation of the lymphocyte development, it leads to different imbalance in the immune system as well as in malignancy. There is the data that's shown on multiple myeloma as well as an immune-mediated inflammatory disease. Hence, it makes sense if you can actually block this cereblon inhibitor, which is the CC220, by blocking this icolose and icarose, that will actually prevent the B-cell hyperproliferation, also will prevent the production of the lymphoplasmacytoid dendritic cells, as well as it will prevent the B-cell differentiation as well. The data has been presented in 2022, consisting of 288 patients in New England Journal of Medicine. At 24 weeks, primary outcome shows there is a difference of effect size of roughly about 20%. And that's a very classical molecule. And there is, to finish up, there is umbilical cord mesenchymal stromal cells in lupus, which is kind of the new talk in the town. And this is phase 1 study. These mesenchymal cells, when you are doing it from the umbilical cord, it actually shows that there is improvement when you treat it appropriately by improving the Treg cells, improving the Breg cells, and also decreasing the Th1 and improving the Treg cells and decreasing the apoptosis. And this is a really very fascinating topic, which is the CAR T cell, which is used in malignancy, but there are 5 patients that have been treated with CAR T cell. This is basically lymphoablation using cytoxan as well as fludarabine. When they did that, they found that in these refractory lupus cases, there is amelioration in lupus. Efavaleukin alpha, this is basically interleukin-2 lutein protein fusion, which actually helped to increase the Treg cells. As you know, Treg is a good guy, and phase 3 studies ongoing. And this alpine molecule is actually fusion protein, which acts on ICOS, and it blocks simultaneously the CD28 and ICOS ligation, as you see in the picture on the right-hand side. So by blocking the co-stimulation, almost like abatacept, as you know in rheumatoid arthritis, it also causes the blockage of co-stimulation and ameliorates lupus. Nipocalimab also is a fully human glycosylated immunoglobulin antibody that actually binds to the neonatal Fc receptor, and actually it modulates that by actually genetically engineering it and causing no terminal lysine, and that actually helps to abrogate the immunostimulation. And this is the telitacicept in lupus, which is a combination of BLyS and April. Remember, Benlysta only blocks BLyS. Telitacicept blocks BLyS and April. And here is the data, the phase 2 data, which looks really promising in lupus. Gazyva or obinutuzumab for the treatment of lupus is also very promising. It is a super brother of rituximab, that's what I call it. It's basically a monoclonal antibody against CD20, but it's a humanized type 2 monoclonal antibody. And phase 3 is ongoing. Phase 2 trial, which is called the Nobility trial, shows a lot of promises. Phase 3 trial is ongoing. And I'll finish it up with deucravacitinib. All of you are very familiar with that. It's a TYK2 inhibitor used in psoriasis. Psoriatic arthritis now been tried in lupus. Enpatoran is also another TLR blocker, TLR7, and this is the data on CD40 ligand called dapirolizumab, which is a CD40 ligand, which actually is an antibody that blocks the interaction of CD40 with CD40 ligand. And this is the data that I'm showing you here at week 24. It is a phase 2 trial, shows really very promising. And Daiichi is the last molecule that I'll talk about, where actually is again another molecule that is an antibody against specifically toll-like receptor 7. As you know, toll-like receptors are very important molecule for lupus. So these two molecules that I told you are actually working against the toll-like receptor. So there is a lot going on in the field of lupus. And I just gave you a snapshot. I can probably talk for 4 hours or 5 hours, but I cannot do that because I'm in a time crunch. But thank you so much for your attention, and I'll be happy to take any questions.